Welcome to Dr. J Explains. I'm Dr. J, physician and finance enthusiast, breaking down complex healthcare and money topics into practical, powerful insights for everyday use. Let's dive in. All right, welcome back to Dr. J Explains. Last week we talked about physician burnout, and this week we're going to talk about Medicare for all. As we get into a political season and you hear a lot of people throw that out as an answer to our health care issues. So let's get started.
All right. So when people say Medicare for all, what are they talking about?
That's a great question. And first, let me explain a little bit about different types of healthcare systems that are found throughout the world, because it makes a little difference. First, there's one called the beverage, like you drink a beverage, almost like that, the beverage system, which is where you have government health care and then all people in healthcare, providers, hospitals, whatever, they're owned by the hospital, they're employed by the hospital. And so the government is kind of the payer, but they're also kind of the owner of all the assets in healthcare. Number two, there's something called the Bismarck model, which is a lot of you would be familiar with because that's where you have employer-sponsored healthcare. And most people under the age of 65 in our country have insurance through an employer, and you may take some of it out of your check to pay for it, and then the employer pays the rest of the premium, but that's called a Bismarck model. Then there is a national payer model where the government is the payer, but the hospital and providers are still independent. They're not employed by the government. And then the fourth one is you just pay cash for everything. So I'm going to ask my co-host Andrew here a question. Which system do we have in the United States?
The Bismarck, I think.
If I told you that's partially correct and actually wrong, we have all of them. That's part of the reason the U.S. healthcare system is kind of entangled. The beverage where the government pays for it and everybody's employed by the government, that's the traditional VA model. The VA model is a beverage model. The Bismarck model is how most people get their employer health insurance right now. And then the national payer is kind of like the Medicare model. Once somebody gets on Medicare, the government is the payer, and then they pay to providers and hospitals. And I think because of some of the gaps that we have all of the systems, we have people that fall through sometimes in our system that don't have insurance at all.
Mm-hmm. So when you hear kind of people calling for changes in Medicare, which I think or healthcare, what do you think, kind of the reasons that they're asking for that? And then what do you think the things are they just don't really understand without being involved in healthcare that are issues?
Good question. I think the first two things that jump out in my mind is we as a country spend an average of $9,000 per individual in this country every year on health care. And a lot of other developed countries, maybe 5,500, on the high side, 6,000. So we definitely spend more money than other people do. And it's also 20% of our gross domestic product. One in every $5 in this economy that is generated in our country is spent on healthcare. And then we have 27 million people that aren't covered. And then people feel like healthcare is very expensive. Healthcare insurance is very expensive. And then when you go get something done, that's when you discover about your deductibles and copays. And there's still a lot of out of pocket spending in our system that I think drive people crazy. They say, well, I can't afford to pay all these deductibles and copays because I had to pay this much for health insurance. Well, when you're sitting there in front of the provider, the hospital, the physician, the nurse practitioner, the physician's assistant, they're not paid anything by the. And at that point, they haven't been paid by the insurance company or whatever. Your insurance contract is your insurance contract, and it gets very confusing because a lot of people don't understand what their insurance contract is.
And most of the time, for you said 60 something percent of Americans, it's handled by their work. And generally, I guess work isn't explaining the different levels of coverage or only has one level of coverage.
Well, and I'll be honest with you, I think unless you really work at a big company with a big HR department, I bet you there's nobody in your HR department that understands the insurance plan that you have either.
Hmm.
Because they have a lot of other things they have to take care of. And I'm not saying they don't understand the basics better than the employee does, but they really probably don't understand the fine print because they didn't read the fine print. And then when some situations pop up, it's, well, that's not covered.
And you handled a lot of the insurance at y'all's office when you were working. What was the things that kind of you noticed from being on the other side of it that other people wouldn't notice, and kind of why your insurance plans you selected were different than other ones? Kind of walk me through that.
I would say that what I noticed is, I wasn't on the day to day operations of the insurance or somebody's paying. I found out about it when there's a problem.
Mhm.
So,
Like, what were some specific problems that you ran into, and then how did you fix them?
well, a big problem would be insurance company just didn't pay it.
Mhm.
They love to, like any insurance, I think, they love to find a reason not to pay. They want to take your premiums and they don't want to pay. And they're big bureaucratic things to deal with. And one of my most frustrating problems, which was probably worse when I first started to practice, is I didn't understand the buzzwords and everything the insurance company was looking for in the note that I sent in about a procedure I had to do or a test that I was recommending or whatever. Because it doesn't really matter what happens in the patient room. You have to come out and dot the I's and cross the T's while you still have people waiting on you.
Mhm.
And you would think some things like, well, that goes without saying. That doesn't make any sense, but it better be in there in writing and you better know where to point it out. So it got easier as I got a little older, experienced, been beat up around the block a few times, lost
Mhm.
battles with insurance companies to, generally speaking, I want a peer-to-peer review. I want to talk to another physician, nothing personal, but I don't want to talk to somebody who's not medically trained, who really doesn't even understand what I am saying.
Mhm.
And like early on, I would say, well, if you look back 3 notes ago, what you're looking for is right there. They're looking at the note, their last note when they were in the office that was right in front of them.
Mhm.
The other thing that got so frustrating, and even for patients, is it doesn't matter how efficient you are. You could schedule somebody for a procedure 3 or 4 weeks out. You can send the paperwork in. They know that it's scheduled, but they know that it's scheduled on this date. Today's a Thursday where we are. Well, say if it's scheduled for Friday, I guarantee you they're not going to look at it until Thursday afternoon. And then they'll decide that they want more information or you don't have this in the note. And so now the problem is it's so late in the afternoon, they're all leaving. You can't get them the information quick enough. You're having to cancel the procedure for the next day.
Mhm.
Well, from my standpoint, it took up time that I don't have time to put something else in that slot now.
Mhm.
So it just, kind of messed up my day and my schedule. But for that poor patient and family, maybe you've been on a special diet for 4 or 5 days.
Mhm.
Maybe you're going to have a colonoscopy tomorrow
I
and
hope
you're
not.
in the throes of passion, if you know what I mean. And then you get a call from me say, never mind, we can't do that procedure tomorrow because they want this information.
Mhm.
And so that was frustrating. And
But then
that's
it kinda
why,
seems like, well, why didn't you know that they wanted this information? Then it kinda looks bad on you.
well, it does. And that's why I kind of learned that I have all that information laid out in their last note. You really have to lay it out very plainly for them where you don't give them a reason to come back and deny things. So denials were not really a big problem for me toward the end of my career
Mhm.
because I learned, okay, you better dot your I's, cross the T's, put every medicine they've taken before that failed. Even if it's been in there a million times, it doesn't matter if it's not on that last note that they're looking at. Because you really think they're going to look through 100 pages?
No, I wouldn't.
They're going to, when you finally get a peer to peer review, you'll say, look on page so and so, second paragraph, second sentence. Oh, there it is. There it is. Okay, fine. Everything's good. And medicine is also so complicated in the fact that you deal with a lot of insurance companies, and all insurance companies have their own protective uh, electronic systems.
Mhm.
They don't want your computer, they don't want your computers to interact with their computers. So therefore, you have to send everything to a third party that they will allow onto their system. And that third party probably deals with most insurance companies. Sometimes you have to use more than one third party in there for this. Well, a few years ago, I don't know if y'all ever remember hearing about something of Change Healthcare.
Mm-mm.
Change Healthcare, it was actually owned by United Healthcare, but it was one of these third party systems. Well, they got hacked and they shut down.
Mhm.
They handled 40% of all the medical transactions from a business standpoint, and they didn't know what had gone where. Well, it took months, you know, even after they came back into operation after like 3 months, it still took about 6 months after that to unwind the mess and try to figure out who have you been paid for and who have you not. And a lot of those are office visits that they might be paying you $35 or $40 for, but here you are spending $100 trying to collect that 35 to
Mhm.
$40. But they're all that way. It's not just your Bismarck model insurance plans. It's Medicare. It's Medicare Advantage plans.
But now the reason that your computers don't talk to their computers, is this a HIPAA issue
A
or is
lot of it
this
has to do with HIPAA issues because I am required to protect the information that I have on my computer system. If you're an insurance company, you are required to protect the information that you have.
Mhm.
So you're going to put all these guardrails up because, we hear about big systems getting hacked all the time.
Mhm.
I'm sure pretty much everybody watching this is going to have some notification that some healthcare provider that they saw that their system was hacked and their information might have been compromised.
Mhm.
So it happens all the time. So that's why they have these guardrails up. But that's also what makes it so hard to work in the healthcare system. I can make things run very smoothly in my office, in my pod, but I have no control over anything that goes on outside of that.
Mhm. And so, like, these third parties, do you think they're just trying to get them to absorb responsibility so that you don't have the connections here? Because I feel like adding a third party just adds another
It
layer of.
does, but that third party, once they go and they contract with all these payers, we're going to say all these different payers, their system is robust enough, it's big enough that they have met all the safety requirement and languages to communicate with every last one of these providers. I can't afford that as an individual provider. I mean, I would have a, multi-public billion-dollar system out there and 100, computer and cybersecurity experts that work for me. Well, you can do that if you're a big third party provider,
Mhm,
because you can imagine if you're handling 40% of the transactions that occurred and you just get a fraction of those,
mhm,
that's a lot of money.
mhm,
I mean, that's 20% of our economy, as I said, is healthcare. So you're handling 40% of the 20% of charges, 8% of GDP. If I just did my math right or whatever,
mhm,
you just get a small sliver of that. That's a lot of money.
mhm. Now, what as far as, like, the insurance aid not insurance aid, the insurance companies, all that kinda stuff, we kinda covered the complications there. What what do you think is kind of a way that we can still maintain the security, but make it easier so that there's not all this kind of, because the complications create cost. So how can we kind of.
Correct. And I would say the answer to that question is I don't know because I'm not a computer person or cybersecurity expert. But I know back when they pushed electronic medical records, it was going to make everything easier. Our offices were going to be more efficient. All that was a lie. It made everything more complicated, everything more expensive. Costs shot up through the roof. And it really, in my opinion, has not improved patient care. Because, and part of it is, if there was a place out there that I could go and I could see somebody's record who was seeing me, and then my record went into that record, it would make it a whole lot easier, but it doesn't work that way. Because a lot of times, somebody comes in and I can only go by what they told me. I don't have the records from when they went to this ER across town 3 weeks ago. No, they haven't sent me records. I don't have those records. I can't easily get those records. But you have somebody sitting in the office with a problem and you kind of try to do the best you can do. But Medicare for All is not going to fix that.
Yeah,
That's a
and so you don't have access to all of that information,
no.
um, because I guess the patient would have to request that specifically, and I guess that's just something that's most
Well,
people
and I
just
think
aren't
in the
familiar with.
ideal system, the patient would control their record and they would give access to who they wanted to have access to those records.
Mhm. Um, but kind of getting back to the Medicare for all situation, I feel like we went on a little bit of a tangent there.
We did.
Um, but so what do you think are the issues that people don't see coming with that kind of system versus what we have now?
I would say the first thing is a single payer system. You may say, in some ways, that sounds good to people that are out there. We want a single payer system. Well, now you have a single payer deciding what's going to be paid and what's not going to be paid, what's going to be covered, what's not going to be covered. And I can almost promise you when the single payer is controlled by elected political officials, no matter which side, it's going to change. When election times roll around, it's going to change. Okay, we're no longer going to cover this, we're going to cover this. So it doesn't necessarily answer everything. Another issue that I think that people that push Medicare for all, there's a senator that's very famous. Y'all all know who probably pushes Medicare for all more than anything else. And one thing he talks about all the savings that we're going to get from paying Medicare reimbursements to all the providers, that we're going to save a lot of money doing that. Well, first, I can tell you, every provider that I know and every hospital that I know will go bankrupt and out of business if those are the rates that are going to get paid. So I think for some of the claims of all the money it's going to save are probably a little bit exaggerated. At best, I think the
It's going to save money by shrinking the system.
right, the cost may be the same. Number two, those 27 million people that aren't insured that are now in the system are probably behind on services. And so it may actually increase the cost of health care and not decrease it, at least initially.
Mm-hmm.
The other issue is, what about those, half a million people that have jobs through insurance companies? They support your local economies and everything else. You're just going to throw them out of jobs. Now, you could argue, well, you're going to have a few more jobs over here in the government
Mm-hmm.
to take care of that. And that would probably be true. So I think the pros would
But I also
be,
don't feel like anyone's going to feel bad for insurance companies. That doesn't seem to be kind of
well,
a
and I think what most people think of the insurance company is somebody sitting on the top level, a CEO, making a lot of money, making multi-millions, $100 million a year,
by denying
uh,
coverage to.
for what they don't think about is the everyday people that are there making 50, 60, $75,000 a year, who are there every day, who work hard, who do the job they're supposed to do. And that's most people that work at the insurance company.
Mm-hmm.
So the argument is, and we're having an argument in our society right now. Is capitalism bad? Is socialism better? Well, first of all, realize Medicare, a single payer system with private providers, is not socialism. I wouldn't necessarily call it capitalism either, because there's no competition. Um, is there anything wrong? A lot of people don't realize, they think that the market is evil, and they don't realize that their retirement plans and everything else are invested in the market. And so whether they think they're invested or not, the majority, not everybody, but I think it's almost like 2/3 of Americans have exposure to the market in some way.
Mm-hmm.
So it always comes down, is healthcare a right or is it a privilege? And I would say there's three things with Medicare for all we should consider. Three things that I always thought were important. Number one, we want to cover everybody. Number two, we want to provide quality health care. Number three, we want to do it for an affordable price. I don't know how you get all three of those.
Mm-hmm.
I could probably work out a system and I can get you two of them pretty easy. Which two do you want?
Mm-hmm.
Well, it's like, I want all three. I don't want two. I don't think it's a question of, I just want, these two or these three. When you're young and healthy, you probably just say, I want everybody covered and I want it inexpensively, because chances are you're not going to have a lot of interaction. As you get older and have problems, you want quality coverage when you plug into the system. So I think that's important. I mean, I was just reading a statistic yesterday that healthcare costs are covered right now about 45% by the government and Medicare and Medicaid. Because remember, as people get older, which is generally Medicare, Medicaid is generally for people that, low income. On Medicare, they're older and they probably have more health
Mm-hmm.
problems. And then what's left is split pretty evenly between out-of-pocket cost and what insurance companies reimburse.
Mhm.
So when people feel like, yeah, I'm paying a lot of money out of my pocket. Now, I went on another recent trip to Europe. I went to Greece and I've been to Spain before, and I've looked at their healthcare systems.
Mhm.
And the people there will say, our healthcare is free. Now, what they really mean is it's free at the point in which you use it.
So there's no out of pocket.
There's no out of pocket when you go to use it, but their uh like employee payroll taxes are 30.4%. I
Mhm.
don't call that free.
Mhm.
And I think what people here got to understand, if you went to Medicare for all, yeah, your health care premiums, your deductibles, your copays may go away, but your taxes are going way up.
It's just coming at it. You're just not even
Right.
seeing it in
You're
your
robbing
paycheck.
Peter to pay Paul.
Mhm.
And so I guess the question is, would you rather trust your health care coverage to, it could be profit driven insurance companies or a very bloated bureaucratic federal system? And I think I hold my nose on both of them,
Mhm.
but because both of them have their issues.
Mhm.
But you'll hear a lot about Medicare for all. But I would just say be very careful in a political system when people offer you stuff for free. There is no such thing as a free lunch. You can talk about where we're going to tax
Well, if
the
they have the ability to give it to you, they have the ability to take it away.
exactly. That's a good point. I hadn't thought about that, but that's exactly true. Except our elected officials are very reluctant to take anything away once they give it. That's why I'm very skeptical of the government, but we need more healthcare reform. But the only thing you hear right now, at least on the internet, on social media, is Medicare for all. Well, I think we need some competing visions. Competition is never bad for anybody. But I think we need to get some competing ideas of what they would do to fix healthcare.
So if they asked you, called you in front of all the suits up in Washington and said, "All right, what would you do to make this system, as efficient as possible?" Because I mean, obviously, spending $9,000 a person when other places are spending 5,500, kind of piecing through. All right, how much is that actually the case? How many, because I know up in Europe and Canada and stuff, they have the single payer or whatever
Right,
systems covered
right.
through there. But there are issues that no one likes to talk about. Like if you break your leg, you're not gonna. I think it was like an X-ray or something for like 8 months, 9 months, or I think it was like I think it was an ACL or
Well, I
something.
think, and it may be a little better than that, but I can tell you when I looked at the facilities in Spain, you're not going to like their healthcare facilities. They're not nice.
Hmm.
You got to bring your own sheets, your own towels. Uh, I was going to say we definitely have better medical facilities here as with some of the investment that we put into healthcare. But
But is a fresh coat of paint justified a whatever increase in cost? How's the level of care that you get in Spain, Greece, Canada
well,
versus
listen,
the US?
about every doctor we met in Spain said the quality of care, they call it the quality of sick care in the US
Hmm.
is better than it is anywhere. They said they can't compete with it. They don't have the technology we do. They don't have the other thing. They said the physicians are better trained. So sick care, health care, sometimes I think as talk about that Mediterranean diet, their genetics, they walk everywhere. But if they ask me, I would say, and I haven't really worked this out other than just this quick one bullet point. If we could almost break that Bismarck model where you have private health insurance providers, but they're not necessarily through your employer. You say you could get one when you turn 26 years old if you came off your parents' policy.
Hmm.
And kind of like a life insurance policy, other things you get, the earlier you get it, the less it's going to be through your life.
Mhm.
And you can take that wherever you go. Now, if your employer wants to help pay for part of your plan, that they can do that. Set mechanisms up where they can fund your health care if they want, but you pick the health care that you want and let it follow you around. I think that way there would be true competition in prices.
Mhm.
Uh, y- So I don't know. I think something like that may help too. But I also say they should all have to speak the same language.
Mhm.
We shouldn't have to play these games we have to play with dealing with this one, this one, this one, this one, this one, this one. There ought to be set things that they cover, and they cover them for the same reason. And you don't have to do this for that one and this for that one. And
Mhm.
because physicians spend a lot of time, providers, not just physicians, but they spend a lot of time playing those games.
Like, how much time? If you're say you're at work, just say an 8-hour day, I know it's different, but if you're trying to see patients for 8 hours a day, how much time are you actually spending every day dealing with just paperwork?
2/3.
2/3?
Yeah. If you actually put a clock on me and said, okay, we're going to time how much time he's in the room and how much time he's not in the room.
Mhm.
Because I don't think patients understand how much has to go on when it's there. And that I'd
Yeah, they're
say,
just the doctor only was in here for
yeah,
5 minutes.
yeah. But of that 2/3 of time, I bet half of it is spent on making it. I may be doing the note, but making sure everything's just right with the note, where the insurance company doesn't come back and bonk me because I charged a level 4 visit, but it said, you talked about this. Yeah, but they had all these other health problems too that I got to be sure in my note to say, yeah, but we had to understand how they fit into this and they fit into the treatment.
Mhm.
And you may change your treatment. So a good bit of it.
Mhm. So what do you think what kind of things would free up providers to spend, let's just say instead of 2/3 of the time, a third of the time, so that you claim back, more.
GoPro camera on my head.
As an OBGYN, I don't think people are
Yeah,
going to
it's
be
probably
okay
not
with that.
good, but I'm going, why can't I just record
The meta glasses.
everything that we talked
Mhm.
about? And you can just go back and look up the tape when it's over
Mhm.
with. And so, um, I don't know, because I think the whole thing about notes, to me, my notes in the office are more important for me than they are somewhere else, where I understand when you come back the next time what I did before, what we've tried before. All
Mhm.
those other 5 pages of stuff,
Mhm.
I'd stop there a minute, of stuff, I mean, they're not really necessary,
Mhm.
in my opinion. They're to make the insurance company happy or the lawyers happy, or I'm going, why do I care if they're happy?
Mhm. It's one of those things too where, you know, part of this kind of what I saw was the amount of just bureaucracy that's gotten piled on top of medicine. There was a chart that it was, you know, physician is pretty flat, and then the bureaucracy just jumps up in exponentially from there.
There was a commercial, I don't know, probably 15, 20 years ago. And it was about the government was supposed to make mortgage applications simpler. That may
Mhm.
have been what led to the housing crash. And there was a stack of paperwork on a desk, and it was this high.
Mhm.
And somebody says, hey, I thought we made this easier. And somebody said, oh, yeah, we did. And they pulled one sheet off of it and walked out of the room. So that's kind of how, when they feel like they're making your bureaucracy better, said, oh, we're making your bureaucracy better, but fill out these 10 forms over here so we can
Last year it was
see.
11.
Yeah,
We're
yeah,
10% more efficient
yeah,
now.
yeah. That's the whole
Well,
thing about
9 point
electronic
something.
health records. They were going to make care better. Really? Because I clicked a certain box on a computer screen that has nothing to do with why they're here today.
Mhm. And so how do you kind of balance that with, obviously the levels of bureaucracy are there to prevent, edge cases from happening. And so how do you go, all right, we're going to have a lot less bureaucracy, but also balance this with the fact that when you take out levels of bureaucracy, you're going to have these edge cases pop up again.
Well, I would argue that even with all this bureaucracy, the edge cases still exist.
Mhm.
And I've always said what I've noticed as an adult when there's a problem, and it could be from, you could have one person causing the problem.
Mhm.
Instead of addressing that one person, they make it difficult on everybody. I'm going, well, why don't you go get the bad player?
Well, I think we've kind of gone pretty far. We may have to make this into a part 2.
A regular debate, healthcare news,
Mhm.
and why Dr. J is not happy. Thank y'all. See you next time.